Hi, everyone. If you would just give us a moment, we're going to get started in just a second. Hang tight. We're going to let a few more folks join, and we'll be getting going in just a few seconds. Everybody who's just joining us, if you could just give us a few seconds, we're going to give it one more minute, and then we'll get going. Appreciate everybody. Okay, let's go ahead and get going. Good evening, everyone. Thank you for joining our Men's Health webinar. I'm Preston Brickner. I'll be your host and moderator. Going to start with a couple quick housekeeping items, and I'll turn it over to our speaker. First off, your attendance tonight is completely anonymous to all the other attendees. No one can see your face nor your name. Any comments or questions will only be seen by myself and Dr. Segal. If you wish to ask a question, just type it in the chat box. It should be at the lower part of your screen. We'll do our best to include as many of them in the Q&A session at the end of the presentation. Our presentation tonight will last approximately 1 hour and will be presented by Dr. Robert Segal. Dr. Segal is a fellowship trained in male sexual medicine. He practices general urology and specializes in male sexual dysfunction conditions. Dr. Segal earned his medical doctorate degree at Canada's McGill University of Medicine in Montreal, Quebec, where he also completed his general surgery internship and urology residency. He then completed a fellowship in male sexual medicine at Johns Hopkins before joining Chesapeake Urology. Dr. Segal, thank you for your time. Go ahead, take it away, sir.
All right, good evening, everyone. Thank you for attending. Just before I start, Preston, oh, there we go. Okay, I now have control. Thank you. So I appreciate everyone's attendance tonight, and it should be a good presentation, informative. Hopefully you all can learn something, and I certainly look forward to any questions that you have. You can just type them in the chat, and I will get to them probably just at the end of the conversation or at the end of the presentation. So, all right. So this is just by way of reference. This is a great website that has a lot of information on ED. So you can either text ED Cure to the number above, or you can scan the image with your phone, and it'll take you directly to that website. This is my bio, and this is the coordinates of my office. All right, so we'll first start by talking about erectile dysfunction. So what is it? It's the inability to achieve or maintain an erection rigid enough for penetrative sexual intercourse. It's very common. Up to 1 in 5 men at over the age of 20, so even young men will experience this. And the risk goes up as men age. And so you can see at the bottom, 39 million men at the very least are affected with this. So it's a huge problem nationwide and worldwide. So the way an erection works, and this is kind of a cartoon here, but hopefully you can appreciate it. What happens is you have blood flowing into the penis through these arteries. These are called the cavernosal arteries. And as that happens, the penis, this spongy tissue here, this is called the corpus spongiosum, gets filled with blood. And you can kind of see that here. As the erection happens, the veins that drain the penis, which are here at the periphery in blue, become compressed. And that way the blood is coming in, but the blood can't go out. And that's how the erection is maintained. So the key to an erection is sufficient blood flow so that the penis can become engorged and rigid, and then those veins to work effectively so that they can be compressed, and that allows the erection to be maintained. So there's different causes of erectile dysfunction. The main ones are going to be vascular. So what can impact on blood flow to the penis? So coronary artery disease. So the same problem that happens in the heart where plaque or atherosclerosis builds up and blocks the arteries to the heart. Same thing happens in the penis. Unfortunately, the arteries in the penis are much smaller than those in the heart. So sometimes having erectile dysfunction can be a precursor to heart disease. And what are the risk factors of that? Diabetes is a main one. Smoking, high blood pressure, high cholesterol, all of this can contribute. ED can be the result of prostate cancer treatment, which may disrupt blood flow, but it may also affect the nerves. So in order for the penis to get the signal to allow those arteries to expand to get more blood to the penis, the nerves need to function in order to stimulate those arteries. So in men who've had their prostate removed, those arteries can be damaged. The nerves can be damaged, which can impact on the penis's ability to get erect. Men who've had radiation, the arteries can be affected, the nerves can be affected. Another main cause is medication. So, for example, I saw a patient today who is on medication for his blood pressure. So blood pressure can be a very challenging thing. If it goes untreated and it's too high, that can lead to damage to the arteries and erectile dysfunction. But sometimes the medication that allows those arteries to dilate, so you're getting more blood flow to the penis, that can be compromised by those medications. So just to focus for a moment on diabetes, unfortunately, this is very common in this country and throughout the world. I always tell men that ED may be the least of the problems in people who are diabetic. If it's poorly controlled, it can lead to kidney problems. It can lead to vision problems. It can lead to people needing their limbs amputated. So it's a huge problem, and once it's diagnosed, it's critical that people take it seriously, follow their doctor's advice in terms of diet change, in terms of treatment, which allows the condition to be controlled. So I alluded before to the nerves not functioning, or neuropathy. Again, that can happen after prostate cancer treatment, but the same way diabetics may have issues with sensation in the palms in their fingers or in their toes, and they lose sensation or they're numb. Same thing can happen. The nerves don't function. So the nerves that control the penis don't function well, and that can lead to erectile dysfunction. Factors that may increase ED in men with diabetes. So advancing age, again, that could be a risk factor for any patient, even with or without these other risk factors. Diabetes duration, sugar control, the presence of other problems like vascular disease. So all these things are important and need to be controlled to optimize diabetes control, and hence erectile dysfunction. I always tell people, if they have ED and they're diabetic, it's important to keep the sugar under good control, which will hopefully help to prevent the ED from getting worse. But unfortunately, very often, once the damage is done, it can't be reversed. So now focusing on heart disease, again, I alluded before that there's a link between heart disease and ED. The same process that affects the heart affects the penis. And because the arteries of the penis are much smaller, ED can precede or happen well before symptoms like chest pain or shortness of breath. So in a man who's coming to see me for ED, who's never seen another doctor before, of course, I'm going to treat their ED, but I'm also going to refer them to an internist or a primary care physician to get their heart evaluated. So arteries supplying the penis, again, are smaller than those in the heart. So we kind of talked about this. So it takes a lot less for a small artery to become obstructed with this atherosclerosis than it would an artery in the heart. So you may reduce the risk of ED, again, with healthy lifestyle, so eating well, exercise, losing weight if overweight, quitting smoking if you're smoking, reducing stress is always helpful. Okay, let's talk for a moment about hormonal causes of ED. So low testosterone. So testosterone is the hormone that gives a man his vitality. Men with low T have low energy, low sex drive. They can have erectile dysfunction, which could be related to that, or it could be totally unrelated. It's more likely in men with obesity, which can be associated with all these other conditions. There are different treatment options to manage low testosterone. Some of them are listed here. But being on testosterone alone may not help to supplement blood flow to the penis. So again, we talked about how blood flow is critical for normal erections. So men with low testosterone may not have as good of a response to the oral medications to treat ED, for example. So by normalizing the testosterone level, that may help the response to some of these treatments, but it will not help blood flow itself. So testosterone alone may not be a great treatment for just ED. All right, well, we'll talk for a moment about prostate cancer. Unfortunately, another very common cause of erectile dysfunction that I see, especially men who have been treated. So you can see in this diagram that the prostate is right here, and the nerves that control the erections run right along the prostate. And so in removing the prostate, or if the man is treated with radiation, for example, those nerves are right in the vicinity of where the treatment is going to happen. And unfortunately, even if the nerves are spared, and very often you'll hear the term, especially during surgery, nerve sparing approach. So the goal is to preserve those nerves to help the patient recover erectile function, even if they're preserved, but just having been manipulated, for example, that the nerves can get damaged, and that can impact on long-term function. Sexual dysfunction after prostate cancer treatment is very common. That can be both the erection or rigidity, as well as orgasm function, ejaculation, sensation. All of this can be affected. Not uncommonly, and we'll cover this later. Urinary control can be affected, which can further impact on sexual function. Peyronie's disease is a scarring condition of the penis. And again, the cartoon is depicted here. You can see that fibrous plaque on the top, which is causing curvature. This may impact on the erections, because never mind the curve that may make penetration more difficult, but that scar tissue or that fibrous plaque can impact on the penis's ability to trap the blood. So those veins that need to get compressed in order to keep the blood flowing in there, sometimes that doesn't happen as a result of the presence of that plaque. And so men may have curvature, but they also may notice that, hey, the penis is not getting as rigid as it did prior to the onset of this. So there are certain treatments that are listed below in terms of treating Peyronie's disease, but in men who have ED and Peyronie's, that may impact on the treatment decision. And what's listed down there, penile implant or penile prosthesis, is a common one that we'll get to momentarily. Okay, so now we're talking about treatment options for ED. So just to mention these at the outset, these are some newer treatments that are considered experimental or investigational, and may not be readily available, or should be offered, perhaps, let's say, outside, other than in a clinical trial. So extracorporeal shockwave therapy is a treatment that I'd say is becoming more mainstream. Our practice offers it, and I can certainly talk about it later if someone wants. So there's, I'd say, more evidence for that than these other two, intracavernosal stem cell therapy or platelet-rich plasma therapy, where there's very little evidence right now that is of benefit. So the shockwave therapy is an option for the right patient. But moving on now to the more conventional treatments, we have here several of them: oral medications, injections, vacuum erection device, urethral suppository, or penile prosthesis. So we'll kind of talk about each of these. They each have their own pros and cons, risks and benefits, that again, the patient and the physician would have to kind of come together and decide which treatment is best suited for that individual patient. We'll start with the oral therapies, or the pills. These are usually the first line therapy. So if someone has never tried anything for ED, this is a common first line approach. They're typically pretty effective. There are different options out there. Probably the main ones would be sildenafil, which is the generic for Viagra, or tadalafil, which is the generic for Cialis. The kind of common general side effects: headache, nasal congestion, facial flushing, having an upset stomach. And there are certain nuances about how to take them and the best way of using them, again, that we can cover if necessary. Certainly men who take nitrate medications, that's medications like for angina, so chest pain. People can put a spray under their tongue, or they can put a little tablet under their tongue. They should not be taking these medications. Next option, penile injection therapy. So this is something that is used commonly in the event that the pills don't work. It's basically a patient administered injection of the penis, done typically a few minutes prior to attempting sexual intercourse. It can work well. You can get a pretty natural erection. Unfortunately, it's cumbersome. It requires more planning. It's less spontaneous. There can be pain. There can be bleeding or bruising. A common issue is these treatments are typically not covered by insurance, so there's a cost associated with them, and there can be certain rare side effects like prolonged erection, or scar tissue formation, which can result in deformity of the penis. Next is the vacuum erection device. So this is an external device that you apply to the penis. There are those that are manual. There are those that are automatic. So you kind of flip a switch and it generates a suction. So blood is drawn into the penis by vacuum. Very often you have to use a tight ring here at the base of the penis, which is depicted, to keep the blood trapped in there. So it's a good treatment in that it doesn't involve needles. It doesn't involve medications. But the type of erection that you get can be a little atypical. The penis can be cold. It can be numb. That ring may impact ejaculation and may cause discomfort or bruising. So it's not uncommon, for all of these second line options other than the pills, that the patient tries them, but for one reason or another, they're not satisfied with them and they move on to a different treatment. The urethral suppository is another option. The one that's depicted here, to my knowledge, is not readily available at this time. So I use a special, it's like a gel that comes in a syringe. So basically what you do is you inject this gel through the pee hole into the urethra, and the medication absorbs through there into the penis. So it's similar to the medication that you would inject. It's just being administered in a different way. It can work. Some people prefer it because it doesn't involve a needle or this cumbersome device, but kind of similar side effects. It can cause some penile pain. It can cause some bleeding. Sometimes if the medication is not absorbed into the penis, it may get deposited into the partner. And so the partner can get some side effects like some discomfort or aching. So again, another treatment where the dropout rate is fairly high. So the definitive treatment is going to be a surgical implant that's depicted here. We probably have a video of this upcoming. So basically what happens is you have these two cylinders that go in the penis. They connect to a pump that sits in the scrotum in between the testicles, and then a fluid-filled reservoir that goes up in the pelvis as depicted there. And basically how it works is when the patient wants an erection, you feel for that pump through the scrotum. So everything is internal. There's nothing that's visually evident that you have this. And by manipulating that pump, the fluid gets transferred from that reservoir into the penis, into those cylinders. So that's how you get the erection. And then when you want to get rid of the erection, you hit the deflate button and the fluid gets transferred back into the reservoir. So it's a self-contained hydraulic device that is pretty inconspicuous and works well. Patient satisfaction typically is very high with this and is commonly higher than the other treatments that I had mentioned before. I think part of that is it allows the patient to be fairly spontaneous. Once the patient is familiar with the device and has practiced with it, it may take a minute to get it fully inflated, and then you're ready to go. The erection can stay as long as you want it to until you deflate it. It does require some practice. I always use the analogy that when I first got my contact lenses, it was taking me 20 minutes to get them in. Now it takes me 30 seconds. So same thing with this device. The more you practice, the more you get the hang of it, and the easier it becomes to use. The two main devices that I use are the 3-piece inflatable or the malleable. The vast majority of men get the 3-piece inflatable. The 2-piece inflatable is available if there's a reason why the patient cannot have an abdominal reservoir. That happens very infrequently. As a matter of fact, in my practice, I've never put one in just because I either am able to get in the reservoir, and there are various ways of doing it, or in some men, the malleable device. Oh, wait, let me just go back here. The malleable device are basically these 2 rods in the penis. So you kind of have an erection all the time. You bend the penis down when you're going to have sex, and you bend it up, kind of tuck it under your waistband like you did when you were in high school when you're not using it. So the advantage of the malleable device is for patients who have issues with manual dexterity or hand strength. They have a tremor, they've had a stroke, and their hands are weak. They're still able to function and be active. The 3-piece implant, just to kind of talk about this a little bit more. One of the biggest risks is infection with this device. So as would be the case with any implanted device, whether it's a penile prosthesis or an artificial knee or a heart valve or something like that, there is always the risk for infection. So fortunately, these devices are coated with an antibiotic solution that has lowered the risk for infection. In most studies, the risk is about 1%. Some men may have a higher risk of infection, such as people who are diabetic. Another reason to keep the diabetes under good control. Studies have shown that the risk of infection may be higher in men who have poorly controlled diabetes. This line on the bottom here is important. That this technology has been around for several decades, and there are many men over the years who have been implanted with good success. So this is a video. So yeah, Preston, you might need to click on this to play it. There you go. So here, this is a cartoon. The patient here is manipulating the pump, and in so doing, transferring the fluid from the reservoir. So you can see that deflating in that little window, and the fluid is going into the cylinders and engorging the penis. When the patient is done using the device, they hit the deflate button. The fluid gets transferred back into the reservoir, and the penis gets flaccid. All right, so we'll move on. Okay, so what to expect with the procedure. So in our practice, most commonly, it's an outpatient procedure performed under general anesthesia. There are some patients, like for example, I just had a patient I found out today, just because of his other health issues, he's not a candidate for surgery in an outpatient center. It has to be done in the hospital. So sometimes that's necessary, but most of the time it can be done outpatient, which means you go home the same day after the procedure. The incision is done either in the scrotum or above the pubic bone. I tend to favor the scrotal approach. It's typically a few days of recovery at home, taking it easy, perhaps being off work for a week or two. And then about 6 weeks of healing before I show you how to use the device and then release you to full activity. My main restriction is no heavy lifting or straining during that procedure, during the 6 weeks after the procedure, just because you need to kind of heal. We want the components of the device to kind of scar in. If you're too active too soon, some of the components can move and it can make recovery more challenging. Typically, the penile prosthesis is covered by most insurances. Not every insurance, unfortunately, and we've encountered patients where their insurance typically does cover it, but the employer has excluded it, or that particular plan doesn't cover it. So unfortunately, that's something that is a reality for some people, but that's something that we look into and verify before we move ahead. So these are just kind of testimonials. Most men typically are very happy with the device. It allows them to recover function and not need to take pills, not need to do injections and wait for these treatments to work. And sometimes they may not work, or they may not work to the patient's expectation. So fortunately, it can kind of recover a function that was lost. I try to be realistic with patients. It may not be like the best erection they had when they were 20 years old. Typically, orgasm function shouldn't change. Ejaculation shouldn't change, for better or for worse, meaning if the patient had prostate cancer and they lost the ability to ejaculate with that treatment, it's not going to be restored. Sensation shouldn't change. A lot of concerns that men have revolve around the length of their penis. And unfortunately, in a lot of cases, men have lost length due to prostate cancer treatment or scar tissue formation from Peyronie's disease. So the purpose of the device is not necessarily to lengthen the penis, but we put in the biggest device that fits. So this kind of just summarizes, very high patient satisfaction with fortunately low risk of complications, typically covered by insurance, typically pretty durable, and pretty inconspicuous. Again, we can talk about the complications in detail if someone wants. The main one, as I talked about, was infection. Some devices, as even though the durability is pretty good, they can fail. In some studies, up to 80% at 10 years are still functional. There was a study not long ago that showed that at 20 years, up to 50% are still functional. But if the device does break down, then it would mean another surgery to remove the old device and put a new one in. So in summary, about ED in general, it's a very common condition. There's a variety of treatment options, and it's incumbent on the patient and the physician to determine the best treatment for the individual patient. You can take a look at these references. I'm just going to kind of flip through them here.
Should be one more. There we go. All right, everybody. Thank you. Thank you, Dr. Segal. Always learned a lot from you. Everybody, if you could, don't be shy. Again, only Dr. Segal and